Thank you very much, and thank you for the honor of being able to speak with you all today. And I think as a nice sequelae to our prior two excellent talks on variants and whatnot is to talk about some of our special patient populations. So I'll be speaking today on how the impact of COVID-19 has been on our immunocompromised individuals. As mentioned, I'm an infectious disease physician here in Boston at Brigham Women's Hospital, associated with Harvard Medical School, and my focus is on transplant infectious diseases. So the way the CDC has defined who are considered immunocompromised when it comes to COVID-19 and other illnesses is that we know that many conditions and treatments can cause someone to become immunocompromised. And what are the key conditions that we're focusing on here? So those that have received a solid organ transplant or a hematopoietic stem cell transplant, but that was recently, within the past year. Those who are on active or recent treatment for solid tumor or hematologic malignancies, those that have a severe primary immunodeficiency, or those with advanced HIV that either are not on treatment or not yet responded with a low CD4 cell count. Limited data suggested that those that have well-suppressed HIV do not have an increased risk for severity of disease for COVID-19 to date. Or individuals who are on prolonged uses of corticosteroids or other immune modulators or immunosuppressives, particularly anti-CD20 agents such as rituximab. And so we know that having a weakened immune system can increase the risk of severe illness from COVID-19 like it does with other illnesses as well. And why is that the case? So here just depicts when an individual is impacted with a low virus titer compared to high virus titer of SARS-CoV-2, what then is activated in our immune system and what then is a sequelae that then leads to either mild disease or more severe disease and ongoing organ failure and ultimately death. So we know that in order to have an adequate immune response to SARS-CoV-2, it requires an innate and adaptive immune response with a quick type 1 interferon response, and as well as activation of efficient antiviral responses in order to clear the macrophages, as well as activation of our T helper cells and B cells for production of neutralizing antibodies. So what goes wrong when you have an inadequate immune response? Well, the opposite of what we just talked about. You then it results in endothelial cell death and accumulation of activated macrophages going on to lead to this cytokine storm, which we then know when it gets to that point, our limits as far as treatment then are very limited at that point and more than concerns for organ failure and mortality. So when we think about the immune-related risk factors for susceptibility to severe COVID-19, we think about this often in terms of age. Those older individuals who have an impaired B cell and T cell immune responses versus younger individuals. And having an impaired B cell response, meaning the reduced ability to mount a neutralizing antibody, or impaired T cell responses, and we're learning more and more about the role of T cells in the response and control, particularly the cytotoxic T cells, in helping to really control those who are already infected with SARS-CoV-2. However, we know this is not just age mediated, and that younger individuals, particularly those who are immunocompromised, function and have the same increased risk factors for severe COVID as a result. So we know just in the US alone, we have over 7 million individuals who meet this definition of immunocompromised and many, many more million internationally, and more likely to get severely ill from COVID-19. And why is that? And so as our prior speakers have eloquently talked about, as far as immunocompromised individuals have prolonged SARS-CoV-2 infection and viral shedding. And this viral evolution during infection and treatment, particularly in those that have severe disease and are hospitalized, are more likely then to have viral evolution, are more likely to transmit SARS-CoV-2 to household contacts, and ultimately result in having a lower antibody or neutralization titers to SARS-CoV-2 variants compared to immunocompetent individuals. And these are our same individuals that are more likely to have vaccine breakthrough infections. And so just to touch upon this viral evolution a little bit more, so that although the detection of viral genomic material does not confirm presence of infectious SARS-CoV-2, meaning that just because we know that in many of our immunocompromised individuals, we can still have a positive PCR test for SARS-CoV-2 well beyond the 21-day mark, and many studies have shown up to 100 days, 150 days. But what we really need to know is what of that virus is actually infective. What can we culture for that? And so there was a study that was just recently published that looked at 129 immunocompromised and immunocompetent individuals and showed that you could culture virus anywhere from a median of 8 days up to 20 days. There's preprints also that have shown now that you could culture it up to 78 days and even higher than that. So what does this mean in terms of when we think about the importance of treating the individual, not only for their sake, but also for viral evolution and the emerging variants, et cetera? So when we talk about vaccine breakthrough infections, we know that they have a lower vaccine effectiveness when you're immunocompromised, and that ranges anywhere from the studies being 59 to 72% after the second dose of the messenger RNA vaccine. So I'm talking here about the Pfizer and Moderna vaccines, as compared to immunocompetent individuals, which around the same time period post their second dose have a vaccine efficacy estimated to be around 90 to 94%. So in this graphic here, it tries to summarize the results of 63 studies looking at different patient populations. So if you see here on the vertical axis, it says a percent of those individuals in these different studies that had an antibody response, with the blue dotted line being the healthy controls have an antibody response around 95 to 100%. And then you see down here in blue, cancer patients, with the darker blue being the hematologic cancers. So those individuals with leukemia, lymphoma, for example, having a much less likely ability to mount a good humoral response after the second dose of the vaccine compared to those that have a solid organ tumor. Whereas hemodialysis patients that we think of are relatively, from a clinical perspective, relatively immunocompromised, are able to mount a more robust antibody response than compared to organ transplant recipients. And I think this is very interesting because though we know organ transplant recipients are immunocompromised, we don't think about them usually the same way as far as an organ transplant, such as a kidney transplant patient that's been out 8 years on low-dose immunosuppression, of thinking about them being so much more immunocompromised than, say, other patients that have an immunosuppressive therapy group there, maybe have a rheumatologic condition or a neurologic such as multiple sclerosis and are on different immune modulating therapies that also limit their ability to mount a robust antibody response. But it's really been the case, we've seen very much so that in solid organ transplant recipients, that they have a very much impacted ability to mount a good antibody response. And so this has led to the third dose trials that are now not only being, or previously, while they were being done in the general population, were being done on a much smaller base in immunocompromised individuals. And so this is a study that was published in the New England Journal of Medicine from our colleagues at Toronto that looked at a small group, just 60 patients in immunocompromised versus, 120 total, 60 of whom got a third dose of the Moderna vaccine. And what's interesting and important to note in these studies is that the endpoint was not a clinical endpoint. So in our vaccine studies that we're looking for vaccine efficacy, the endpoint is clinical disease. Did they develop symptomatic SARS-CoV-2? This was all about humoral and T-cell response. And as mentioned, we don't yet have a clear correlate to protection, though that's beginning to emerge, and we have a preprint from the Moderna study to show perhaps where a certain antibody level may actually denote immune protection. However, we don't have that yet. And in this study, it did show, though, that with a third dose, you had a significant humoral response. That was not surprising, I think, to any of us. I think what was surprising is that you still have significant percentage of those in the treatment arm who don't yet have a full humoral response. So what do we do with those? Are there additional preventative strategies for those immunocompromised individuals who do not mount a robust humoral response? Well, we know that it's not only the third vaccine, but now we're talking about the fourth vaccine doses in immunocompromised individuals. And in addition to just the fact of vaccine equity that we need to be concerned about, the other concern is also a theoretical issue with whether or not this will actually precipitate rejection in our transplant recipients. And so what are our other modalities? So I just want to highlight the SARS-CoV-2 viral life cycle in order to be able to highlight why monoclonal antibody treatments is so critical and very important earlier on in disease. So that we know that neutralizing antibodies work to try to prevent the binding of the spike protein of the SARS-CoV-2 virus to the ACE2 receptor, which is what's required in order to have viral entry into the cells. So if you can prevent that, then you prevent the downstream of effect, which leads to then viral replication. And this is why the studies for this have shown it's so important to use this treatment early on in the course. And so when you do use monoclonal antibodies, which fortunately now we have 3 that have been FDA EUA approved, and though the first one, bamlanivimab etesivimab, the Eli Lilly monoclonal antibody cocktail, had initially lost its EUA, it's been reinstated because it does have effectiveness against the Delta variant. The casirivimab indevimab is the Regeneron monoclonal antibody cocktail, which has had efficacy against all the variants to date. And then there's sotrovimab, who received its FDA EUA approval at the end of May. What's very important for this, which has already been highlighted, is the fact of what will this mean as far as efficacy of these monoclonal antibodies with mu and more variants of concern in the future. So just to highlight how important and effective these monoclonal antibody treatments are, this shows a study of looking at, this is the phase 3 study of the Regeneron cocktail, looking at how the reduction of the risk of hospitalization and all-cause mortality in patients who were at high risk for severe disease. And this had led to a 70% reduction in hospitalization and mortality. And then at the end of July, we had the approval for the EUA to expand to not only be for outpatient treatment, but for post-exposure prophylaxis in household contacts. And this was truly a game changer, because this now means if someone has an exposure, you can treat them earlier on and therefore prevent even mild onset disease, and hopefully our immunocompromised patients then limit the chances of ongoing viral transmission. And then there are many studies that are emerging now about pre-exposure prophylaxis, though we don't yet have the approval to do so. And I don't want to completely ignore the fact of what the role potentially could be for this treatment in hospitalized patients, though it's not yet currently recommended, that we do know from the recovery trial data and also preliminary data from the Regeneron study that in the seronegative group, so those individuals who are hospitalized for COVID-19 but have not yet mounted an antibody, they did see an improvement and a decrease in mortality for those that were treated with casirivimab and indevimab. So just to touch a bit on long-term COVID-19 outcomes, I don't want to spend time, we don't have the time to spend on the post-acute sequelae of COVID or PASC or long COVID, but I think it's important when we clinically think about how we are assessing patients in these clinical trials, and generally now as we know this pandemic has continued to go on, is that most of the clinical trials are looking at 20-day outcomes, 14-day outcomes. And this is a study from Denmark that was presented at the ID Week, our international Society for IDs just last month, that looked at their study of incidence of readmissions, post-discharge mortality, and sustained recovery. And looking at sustained recovery at least 14 consecutive days after hospital discharge without readmission or death. And so what they compared was their first wave in Denmark compared to the second wave, seeing that an overall mortality was lower in the second wave, as we know has been the case, fortunately, throughout many countries. And that the hospital readmission or post-discharge death, though, rates were similar and were substantial, greater than 20% at 90 days in both waves, highlighting this limitation of the 28-day outcome measure. And also that though the index hospitalization mortality rate is lower with the 2 waves, that the fact of these post-discharge sequelae have not been lower. So we know that there are many factors that are associated with this that I won't take the time to get into today, but I think it's very important when we think about this again and thinking about longer term outcomes and how this ultimately impacts as more and more of our individuals are becoming infected. And so overall, though, we need to assess what are different ways and different outcomes in order to assess clinically what is the impact of SARS-CoV-2 on patients who develop this, both mild disease as well as moderate to severe. And then I'd just like to end with, because last year I had the privilege of being able to speak to you all along with Dr. Delmonico about the impact of COVID-19 on organ transplantation. And I'd just like to end with one slide on a positive note. We talked about last year about how it had decreased organ donation and led to decrease in transplant, but then fortunately that had all rebounded. And now we're talking about not only we were concerned about donor-derived infections, and now we're talking about how we can actually expand the donor pool by not declining organs from donors who have died of COVID-19. But in addition, a different way of looking at this is that thinking about lung transplantation for individuals who are impacted by COVID. And so this was published earlier this year in The Lancet that showed a case series across 4 countries, the US, Italy, Austria, and India, who did the first 12 consecutive lung transplants for patients who had experienced a COVID-associated acute respiratory distress syndrome. And these had led to excellent outcomes and really showed how we can then push transplant forward in this pandemic to now not only prevent the pandemic from impacting organ transplantation, but use organ transplantation as a treatment for some individuals. So I'll end there and say thank you so much for the opportunity.